Initial treatment of flail chest and pulmonary contusion includes administration of humidified oxygen, adequate ventilation, and cautious fluid resuscitation. Patients with significant hypoxia on room air may require intubation and ventilation within the first hour after injury. Definitive treatment of flail chest and pulmonary contusion includes adequate oxygenation, judicious fluids, and analgesia to improve ventilation. The plan for definitive management may change with time and patient response, warranting careful monitoring and re-evaluation of the patient.
Flail chest occurs when a segment of ribs becomes discontinuous with the rest of the chest wall, generally when 2 or more ribs are broken in 2 or more places. If the flail segment is large enough, the effect can be observed by standing away from the patient and watching the chest wall motion. In severe cases, paradoxical movement will be observed.
Approximately 50% of blunt cardiac injuries are related to motor vehicle crashes, followed by pedestrians struck by vehicles, motorcycle crashes, and falls from heights greater than 20 feet or 6 meters. This condition can result in myocardial muscle contusion, cardiac chamber rupture, coronary artery dissection and/or thrombosis, and valvular disruption. Signs and symptoms of blunt cardiac injury include chest discomfort, hypotension, electrocardiographic changes, elevated central venous pressure, and wall motion abnormality on echocardiography. It is important to remember that the traumatic event may have been precipitated by a myocardial ischemic event. Early use of FAST can facilitate diagnosis. Traumatic aortic rupture is a common cause of sudden death after a vehicle collision or fall from a great height. Survivors of these injuries frequently recover if aortic rupture is promptly identified and treated. Blood may escape into the mediastinum, but one characteristic shared by all survivors is that they have a contained hematoma. Specific signs and symptoms of traumatic aortic disruption are frequently absent. Maintain a high index of suspicion in patients with a history of decelerating force and use radiographic findings for diagnosis. Helical contrast-enhanced CT of the chest has proven to be an accurate screening method for patients with suspected blunt aortic injury. Even a slight suspicion of aortic injury warrants evaluation of the patient at a facility capable of repairing the injury. Obtain surgical consult and control heart rate and blood pressure to decrease the likelihood of rupture. Control pain with analgesics. Traumatic diaphragmatic ruptures are more commonly diagnosed on the left side, perhaps because the appearance of displaced bowel, stomach, and/or nasogastric tube is more easily detected in the left chest. Blunt trauma produces large radial tears that lead to herniation, and penetrating trauma produces small perforations that can remain asymptomatic for years. An elevated right diaphragm on a chest X-ray may be the only finding of a right-sided injury. Occasionally, the condition is not identified on the initial X-ray film or subsequent CT scan, in which case an upper gastrointestinal contrast study should be performed. Minimally invasive endoscopic procedures may be helpful in evaluating the diaphragm in indeterminate cases. Treatment is by direct repair. Esophageal trauma most commonly results from penetrating injury. The clinical picture of patients with blunt esophageal rupture matches that of post-emetic esophageal rupture. The clinical setting of esophageal injury is typically a patient with a left pneumothorax or hemothorax without a rib fracture who has received a severe blow to the lower sternum or epigastrium and is in pain or shock out of proportion to the apparent injury. The presence of mediastinal air also suggests the diagnosis, which often can be confirmed by contrast studies and/or esophagoscopy. Treatment of esophageal rupture consists of wide drainage of the pleural space and mediastinum with direct repair of the injury. Secondary survey, the trauma team should look for these other significant thoracic injuries: subcutaneous emphysema, crushing injury, or traumatic asphyxia, and rib, sternum, and scapular fractures. Although these injuries may not be immediately life-threatening, they can potentially cause significant morbidity. Subcutaneous emphysema can result from airway injury, lung injury, or, rarely, blast injury. Although this condition does not require treatment, clinicians must recognize the underlying injury and treat it. If positive pressure ventilation is required, consider performing tube thoracostomy on the side of the subcutaneous emphysema in case a tension pneumothorax develops. Findings associated with a crush injury to the chest or traumatic asphyxia include upper torso, facial, and arm plethora with petechiae secondary to acute temporary compression of the superior vena cava. Massive swelling and even cerebral edema may be present. Associated injuries must be treated. Pain on motion typically results in splinting of the thorax, which impairs ventilation, oxygenation, and effective coughing. Fractures of the scapula, first or second rib, or the sternum suggest a magnitude of injury that places the head, neck, spinal cord, lungs, and great vessels at risk for serious associated injury. Pulmonary contusion may accompany sternal fractures, and blunt cardiac injury should be considered with all such fractures. Fractures of the lower rib should increase suspicion for hepatosplenic injury. In general, young patients with more flexible chest walls are less likely to sustain rib fractures. The presence of multiple rib fractures in this population implies a greater transfer of force than in older patients. Because osteopenia is common in older adults, multiple bony injuries may occur with reports of only minor trauma. The presence of rib fractures in the elderly should raise significant concern, as the incidence of pneumonia and mortality is double that in younger patients. Taping, rib belts, and external splints are contraindicated. Relief of pain is important to enable adequate ventilation. Early and aggressive pain control, including the use of systemic narcotics and local or regional anesthesia, improves the outcome in patients with rib, sternum, or scapular fractures. It's important for the team leader to quickly establish the competencies of team members in performing needle decompression and chest drainage techniques. Consider the potential need for bilateral chest drains and assess team resources accordingly. Recognize patients who have undergone pre-hospital intervention, such as needle decompression or open chest drainage, and assess the patient's response and need for additional timely interventions. Recognize when open thoracotomy will benefit the patient and ensure that a capability exists for safe transport without delay to a skilled surgical facility.